the idea behind this course was to cover, the course or the surgical way of handling diabetic PDR. And I think we will cover basically topics from how to plan before the surgery and how OCT and other modalities kind of help us in planning a good surgical outcome. Then there are two talks basically on the two ways of handling these cases. So surgically handling them. So one is basically, the two ways of dissection. One is unimanual and one is bimanual, which is always a very hot topic of debate. Then we would be moving on to tackling combined retinal detachments or the morbid PDR cases. And then finally, I think, which every surgeon does face, which are complications. So I think that would be the flow of the program. And I'm very privileged to have one of the best faculty with me over here. I think we'll have Dr. Darius Shroff, who will be talking on OCT, how OCT helps in surgical planning in PDR. Dr. Darius is a vitreoretina consultant at Shroff Eye Centers and the medical director of Shroff Eye Hospitals.
Good morning, everyone. So like Dr. Gagan says, we're going to move in a sequential manner. So first we'll start with how to plan the surgery. So I'll be speaking on how OCT, especially newer advances OCT, can help us plan the surgery in complex cases of PDR. So PDR is actually a proliferative vascular vitreoretinopathy. What does distinguish PDR from PVR? There are three factors which distinguish, and if we keep in mind these three factors, we can always plan our surgery better. Number one is vascular nails. These are the vascular connections between the retina and the fibrovascular tissue. And these always should be dissected carefully. Second point is hemorrhage. PVR, you will not have heme, so you need to have ways to tackle this hemorrhage. And this can also be a clue sometimes to find the plane. And the most important number three is vitreous cases. So vitreous cases, you can see in this animation, sometimes the heme comes and we have the anterior and the posterior leaf of the cortical vitreous, which is the schisis cavity. And you have to be aware of this. So this is not a new concept. It's been studied from Dr. Paulo Stanga's group from the UK also, where they found swept source OCT to be very, very useful to distinguish the vitreoretinal interface, especially vitreous cases. And here you can see the two leaflets of the vitreous cases. So this is one of our own cases. What we wanted to say is that if you go and dissect just under the green arrows, you're going to get the wrong plane. You're going to leave all this tissue there. So you have to make sure you are in the plane of the yellow arrows. And when you have a OCT, you are aware that such a plane exists. So this is the importance. So knowledge of this and identifying it pre and intra-op critical, finding the correct plane, being correct plane is essential for success of the dissection. And it's very interesting that if you're in the correct plane, a difficult case can be simple, but it's right the reverse. Incorrect plane makes a simple case messy and you get lots of complications. So how does the OCT help? It makes best possible to enter the correct subhyaloid plane. You can identify if the attachments are very tight, then you can have a bimanual surgery to start with. You can have precise detection and cutting of the vascular connections and atraumatic removal of the fibrovascular traction. So I think let's move on to some videos. So here we can see this is the surgical video and this is the corresponding OCT. And you can see in this area, you have quite a lot of cleavage plane and you are dissecting here. Now in this area where the arrows are, you can see this is tenting up. This is where the attachments are. So you have to go between the attachments. Now we come to this area, which is the superior part. And here you can see just by putting your assistant to depress, this helps us go in between and get the correct plane. So we are quite fond of doing this. We have an assistant, or if you don't have a good assistant, you can put a chandelier and do it yourself. But this helps you get into correct cleavage plane. What about cases with multi-layered vitreous cases? So this is also a video. You can enjoy the video. You can see when you have something like this, you have to be very careful and you have to go kind of layer by layer till you get into a correct plane. And now we found a gap. So you can see the gap was inferonasal to a disc. So pre-op imaging kind of guided us that this is where we could have entered. Go on, and areas where there are focal attachments, we can kind of avoid those, tackle them later. So this has all been done with a wide angle system, And sometimes we even use contact lenses. So I'll just show you an example of that. This is the area where it's very, very adherent. So again, the gap, finding the gap on the OCT helps us and kind of helps us to delineate where to enter in these cases. And when you enter the correct plane, you can dissect it. And once you've dissected it, it becomes a smaller piece and it's easier to kind of attack. And here you can see on the OCT, it's multi-layered. And now we have put a contact lens, which we do sometimes, not very regularly, and that helps a more precise dissection. So I think this is probably the last case. So here you can see there's a beautiful separation of the vitreous cases just temporally. And the anterior layer of the vitreous cases is quite elevated. So it's easy to kind of enter and separate it. This area, I think this is nasal, is not well separated. So sometimes a little bit of help with somebody indentating helps. And when you have these vascular nails, which I was talking about, so this is the vascular nails. This is where we find it very useful to go right hand, we take the scissor, left hand forceps, and when you cut the nails, the retina just falls back. So this helps with a very atraumatic dissection. So to summarize, OCT is a completely non-invasive tool. You don't worry about patients with nephropathy, etc. You can use it multiple times to assess the right plane. It helps us to be better prepared. You need to spend a little hard work. I think a lot of credit Dr. Cyrus, because he spends a lot of time before every case to see the OCT. Sometimes the young surgeons, we just say whatever is on the table we're going to tackle, but I think it's a good way to do it. And it's more accurate than a clinical exam for the peripheral separation, the starting point of dissection, areas of simple and tough dissection. And one thing which we found is sometimes what we call as TRD is very often a retinoschisis. So I think it's a very important point. Of course, the limitations is that if you have a dense vitreous hemorrhage of very, very peripheral pathology, it will fail. So we have to keep in mind that we have to rely on B scans in these cases, which are not so precise. And in the future, 3D scans may give more information. Thank you.
Thank you, Dr. Darayas. So, as you had mentioned that we are more into going in, but do you really feel that if we are I think we don't have much experience with intraop OCT, but then do you really think that if we really sit down with these scans and study the case before, I think it will be more atraumatic and it will be a better surgical outcome than, was vis-a-vis having an intraop OCT that time? Or do you think that it can really kind of change the way we look at things now?
I think it's always good to have information. It's like if you're going for a war, you have some intelligence before the war, you can always be more successful. Secondly, two things is that if you know that there's no plane or area, then you can start off with a bimanual surgery. Otherwise, what happens is you start it and then it gets very messy, then you switch to bimanual. So I think it's always better if you are prepared, you know it's going to be tough, you know that the plane is not going to be there. Then from the beginning, you can get your best weapons out rather than have to, in a midway of a case, when you're in a messy situation, you are bleeding, then you switch to bimanual. So I think this is one way it can help us.
Yeah.
Dr.
Ritesh.
Since you mentioned intraoperative OCT, what we try to study that in preoperative and intraoperative OCTs where we had good visualization. Most of our pre-op OCTs were able to pick up the findings that we wanted to know. One very useful point was to picking up sometimes a hole under a TRD in a cases of CRD was also being able to pick up. Intraoperative OCT starts to help us once in cases where there are vitreous hemorrhages, where you can't really do a preoperative OCT. You do a vitrectomy on table, you do an intraoperative OCT, especially if you have done macular dissection, you're not sure whether you have a full thickness hole or a lamellar hole underneath it. You want to tackle the ILM or you don't want to tackle the ILM. That's the most useful thing that I have found out in intraoperative.
Thank you.
We don't use it so much in our diabetics. I use it in all the PVR cases, but in PDR somehow we don't use it so often. I mean, it is a personal choice. I think many people have shown that it's very useful. So, but sir, have you used intraop OCT or?
I don't have any experience of.
Ma'am, Dr. Dhanashree?
No.
One more sign I would like to highlight about the vitreous cases is like once you have dissected all the membranes and you feel your vitrectomy is done, but there are small streak-like hemorrhages in the peripheral retina. It means that your vitreous is still present over there.
Yeah.
It's still not gone, so you have to explore that. In that case, you can put some triamcinolone
Yeah.
to identify that residual vitreous. You can remove it.
Yeah,
Thank you.
popularly
That's
known
good.
as the red herring, right?
The red flag sign.
The red
Red
flag.
flag sign, yeah. Yes.
It can happen. I've seen in even like a younger age group, it's more common.
And the sheen also is there, sir? The shine also?
The shine is also
Also.
there. Once you start exploring it, you'll see that it is getting taut, and it is very adherent. It does not come off so easily. It may even cause breaks while
Breaks
you
when
are.
But do you think sometimes is it better to leave it alone?
It depends. It depends. But I have seen, we actually did a study around, but it was a very small sample size, so I can't conclude on the basis of that. But we have seen that post-operative vitreous cavity hemorrhages and post-operative ERM formations more if we leave that hemorrhage over there.
Thank you.
Right. Can I please request Dr. Dhanashree to please join us on stage? So next, I think moving on from understanding how to go in for the case, I think then comes the big debate whether to go unimanual or bimanuals, which are the two ways of dissection. And nobody better than Dr. Sangeet Mittal can help us with this converse dissection, unimanual rocks. Dr. Sangeet Mittal is a chief vitreous retina surgeon at Thindai Hospital, and I think his knowledge on the subject, has corresponded to the number of awards that he's won through his career. Very illustrious career, and we are very happy to have him here.
Thank you, Dr. Gagan, for including me in this course. And my topic for today is this converse dissection unimanual rocks. Actually, I've been propagating this technique for past 10-15 years, and it's always been a controversial, but I'm very happy using it. I'll just the slides.
Slides or not?
So as in the previous presentation also, we learned that the new vessels grow along the trampoline-like contour of the posterior hyaloid, using it as a scaffold, and they progress to form epiretinal membranes, which are fibrovascular and contractile, and combined with the anterior posterior traction of vitreous on all sides, it gives an appearance of a tabletop TRDs. And it's difficult to treat these membranes. It's not just that, not just like a simple ERM that you just go and peel it off. Because these membranes are not glued, it's not like a paste over there, but they are nailed at various epicenters, as Dr. Dries has shown in his previous presentations. At multiple epicenters it is nailed, so you have to go cut one by one all these nails. And limitations of what the current techniques which we use are segmentation, delamination, and the en bloc dissection. There are some limitations, like in segmentation, delamination, usually you need fourth port or combination instruments. And in en bloc dissection also, it's very difficult. It's not possible in all cases. And finding proper plane of dissection remains a challenge in both these techniques. So from our experience, past experience, we have observed that dissections of membrane is, first thing, this is very important, that dissection of membranes is very easy if you have a proper plane of dissection. And as Dr. Dries in his previous presentation showed, that vitroschisis causes second membranes under the prominent membranes. And all these membranes, whether second or third, they are all usually fused with the primary membrane at the optic nerve head. And it's always easier to work around the tractional points than to cut or peel them. I generally use 27 gauge vitrectomy, but for diabetic patients, but it's any small gauge vitrectomy, either 25 or 27. It's an advantage because they have a low flow rate and there's low turbulence and more stable retina while working close to it. They have very small sphere of influence and it avoids retinal tissue being engaged in the cutter while dissecting the membranes. And the small size of the cutter allows it to go even in very small gaps that are present in various nails for effective membrane dissection. The opening is larger and nearer to the tip, so you can grasp or peel and dissect the membranes with the cutter itself, and you don't need extra instruments for that. And what the technique that I'm discussing with you is what we call that modified en bloc surgical technique. You do a core vitrectomy, you detach the posterior hyaloid at the disc and then dissect the membranes at epicenters using vitreous as a second instrument. So a small animation to depict, sorry. to depict what is done. So, okay, so this is a live demonstration. Just go at the optic nerve head and just pull these membranes up like this, and you will get a very proper, good plane of dissection for the membrane dissection. The concerns while we are using this technique is the foremost concern is that the NVD will bleed profusely. The optic nerve head will start bleeding and you will not be able to do anything. But our observation is it is very uncommon. It's not that every patient is going to bleed. Preoperative anti-VEGF also helps in minimizing the risk. And if it starts bleeding, if you feel that it starts bleeding, just don't panic. Just stop for 3 minutes. 3 minutes is the time. 3 minutes, and just close your eye, and the bleeding will stop automatically. There will not be much blood, and it won't bleed again. And once you have stopped, you don't remove the clot from the optic nerve head. Just let it remain over there. Another concern is that it can cause iatrogenic tears, but only if you pull too high and too heavy, these tears may happen. In severe cases with thin atrophic retina, you have to take care. And once you start doing it, you will automatically come to know how much pull you have to apply to avoid these type of complications. So this is a small video. And this is the membrane dissection part is totally unedited. And the patient had a lot of this membrane. So once I've separated the membrane from the disc, now you see it is totally unedited. I've not cut anything, only the speed is a little faster, two times. In the interest of time, you just see I've separated the membrane of the disc. Now I advance my cutter, I cut the membrane like wedge and advance to the periphery from the center. And once I have reached the periphery, I start inducing the PVD from the periphery. And now I can go all around the epicenters to cut these epicenters to cut them all. So one by one, you can take all these epicenters one by one. So you can do a direct dissection, you can do a rollback dissection depending upon the membrane and the retina below. Such a big membrane, such a tough membrane. With this technique, you can dissect it very easily. So I'll show you another case whether just to see whether it works in combined retinal detachments or not. So again, this was a 27 gauge vitrectomy for a patient with PDR and combined retinal detachment. Just pick up the membrane from the disc, just create a wedge between the peripheral retina and the central retina. You just see and just start inducing the PVD in the periphery. Now this peripheral vitreous, it acts as a second hand. It just keeps your membrane taut up, acts like a second hand. What you want to achieve in a bimanual vitrectomy, you can just achieve by having this vitreous over there. And then you just go in and keep on dissecting this membrane easily. And the small gauge vitrectomy also helps because it keeps the retina very stable while you are doing this dissection. So this is 3 months post-op, the same eye. So I'll just skip these parts. I'll just skip the video, this video. Now the advantages of This technique is that it can be performed in all types of tractional detachments. Its surgical time is considerably reduced. Complication rate is again very low, easy to perform peripheral, which is acts as a third hand to keep the posterior membrane held up. Fourth port or combination instruments are not needed, can be performed in the presence of vitreous hemorrhage, can be done even in the absence of PVD, and second membranes are not missed and need not be dissected separately. To conclude, around the table dissection of membranes using 27 gauge vitrectomy is a simple, faster, and attractive option with less complications and can be performed in all types of tractional detachments. Thank you.
That's an excellent presentation, Sangeet. I think Dr. Gagan wants to present the next topic, and then we can have the discussion together for both the topics. So I now invite Dr. Gagan Bhatia. He'll be talking to us on bimanual surgery, the savior.
So maybe you can come on the dais, join us on the dais so that.
Come. Come, Sangeet.
So after Dr. Sangeet's very lucid description of unimanual, I think I need to kind of challenge this the bimanual way. So I think going back to what Dr. Darius had spoken about, studying these cases and understanding vitreoschisis and why it is important to understand this, this phenomena is because to find the right plane of dissection. This basically helps us to first is get the right plane. I think there are adjuvants which I think Dr. Sangeet was also asking about, which have been used. But I think if you have a preoperative OCT wherever possible, I think then finding the plane becomes much easier. And I believe that initially getting into the right plane of dissection kind of makes the case very easier and really helps us in preventing any iatrogenic collateral damage. I think preoperative anti-VEGF is what we all know, and I think Dr. Sangeet has also spoken about it. So coming to why bimanual surgery, I think one is that it gives you very precise way of knowing the or identification of a tissue plane, especially in places where you have not preoperatively studied the case. I think there is very precise detection and cutting of the vascular connection. So as we know that in PDR, it is more the vascular nails which need to be kind of separated. And that makes this bimanual makes it very easy and controlled. I think there is a way of coagulating the bleeders that I'll show bimanually, and also it ensures complete removal of the fibrovascular tissue and traction, though I think Dr. Sangeet has also described it his way in a very perfect way. And second thing, what I always feel is that in a bimanual hand, I think one hand kind of supports the other hand. So you don't have undue tractional, excessive traction going the contralateral way in this. So in this case, this is basically a normal PDR vitrectomy. So in this, as Dr. Darius had shown, this is the same case which he was showing, in which he was getting into the posterior hyaloid. So we thought that we'll continue with the bimanual dissection here. If you see, we have been able to kind of enter into the right plane of dissection bimanually, and dissect the membrane into smaller leaves, and then bimanually take care of the membrane. If you see one hand, you have a very controlled way of holding it, and then you can interchange between cutter, scissor, forceps, and there is no underlying, probably not causing much underlying traction on the retina, or if you would have done it the unimanual way. So in this case, this was a one-eyed lady and her retina was on, and I think the challenge was not to use any tamponade, etc. So there was a bleed over here. So so this is where you have a bleed, and the cutter kind of helps to kind of keep clearing the field. So you basically were using a cutter and a scissor. So the cutter kind of controls the bleed, clears the field, and then you could use probably a flute needle and a endothyothermy to cauterize the bleed. So this is a bimanual way of cauterizing the bleed at that time. And then you can take care of the membranes. And this is the last membrane which was there in this case. So I think a very controlled way, you can interchange between scissors, forceps, scissors. Then coming to this case, which I think Dr. Sangeet had said that very thin retina. So this is a case of very thin retina. Again, if you see in the bimanual way, you can get into the correct plane of dissection. In many a times, the heme kind of helps you to find the correct plane, because if you kind of just cleave it back, you could see. In this case, the retina seems to be extremely thin and very shitic. So any undue force on this retina would lead to a nitrogenic break for sure. So I think at least in my hands, I think bimanual way would be the better way. I don't know if, we'll see in the discussion if really Dr. Sangeet would go ahead with the unimanual way in this case. And so you still see that little bit of sheen peripherally, but, there is, so I think you can probably get into the right plane again over there, and we'll handle that one membrane peripherally and go out to from in to out. And then finally getting into this plane. I think so if you see, all these vascular nails can be attacked very carefully over here. And then with a close scissor tip, you can probably create your plane of dissection and kind of clear all those vascular nails and carry on with the dissection. So this is one step where I feel, and this could be a part of the discussion, is where you see there are these very, very tight connections around the disc. So at least what I personally feel is that, like if you see all those dissections around the disc, I don't know how it would behave if I would have just pulled them the unimanual way and block. I think that is something that we need to learn from Dr. Sangeet, and it also takes us to a very, it would take us to a very good dissection. So I would also be waiting for his comments on this, because usually we would have this kind of this thing. So let's come to the next case first. So, and then this case was completed. Then we have cases like this where you have a membrane with no edge, because the membrane and the retina is all one. So I think you kind of enter into the posterior hyaloid wherever you can, and then obviously with the help of depression, as Dr. Darius had also shown initially, to find the right plane. And the idea is basically to separate the membrane from the anterior extensions. Sometimes these anterior extensions are till the ora, and in this case it is till the ora. So we kind of lift up this membrane and with the help of depression on one side, kind of try and separate the membrane all around, and do the same procedure all around 360 degrees. This nasal edge was extremely, extremely stuck, and there was no way that this was coming off. Didn't want to make a nitrogenic tear. Now this is one step which I want to again could be a very interesting point. If you see that thick layer, seems like that's the area of entry, but if you actually see the area of entry is that very thin whitish membrane which is there. I don't know, at least in my hands, I would never be able to get in the unimanual way. I think bimanual gives you that plane of dissection. Kind of very carefully you enter, and then finding the a vertical clear edge, kind of dissect the membrane into two halves. Again, these vascular nails are extremely tight. So what I personally feel is, if you create kind of a plane of separation around them, hold the membrane with one hand very steadily, and then kind of tackle each and every nail as you go along. And then again separating the all the vascular connection in that area, and tackling this leaf of the membrane is tackled. If you see till the periphery, the attachments are very, very tight. So you could probably find little planes where you can get in and cut them into smaller leaves, but then again I think a complete dissection would need a bimanual surgery. So, and again, if you see over here, the attachments are again very tight. Both the two poles are kind of separated first before the membrane is lifted up, so as to prevent iatrogenic breaks at the edges of the membrane. So we tackle this leaf also the same way, Now we're coming to the first nasal edge. So the nasal edge was extremely tight, and when we were taking care of the nasal edge, I kind of realized that there's a big round mass, posterior subretinally. So I think going ahead with very, very aggressive dissection at this point, because I was thinking that it's imperative that we take off of all the fibrous tissue and the vitreous, and probably have a break over there, a retinotomy over there to tackle the subretinal membrane. So this was again taken care of bimanually, and then we kind of took this subretinal hemorrhage mass out. So like a big monster. So this is a bimanual way again of taking out hand-on-hand technique, and then finally the case was settled and tamponade was used. So I think to summarize, I think we go back to the principles of PDR surgery. I think we've covered the two techniques, and we have covered the preoperative assessment. I think understanding vitreoschisis is very important. I would say yes, cut a scissor, forceps scissors, and I usually go with the outside to in approach. One point is that it helps you find the plane of dissection, which is again debatable from the unimanual point of view, but at least I feel that once you have separated the anterior surface, you do a good base excision, then even the in and out of the instruments and everything, I think you would probably not cause any undue traction on the peripheral base. And I think very controlled handling is important, and patient and persistence always pays. Thank you. Sir, I think you should come on a dial. Second video. You want, yeah.
I think that
Can I have the slides back, please? These slides back.
really very excellent, very well done. Of course, there is no hard and fast rule whether you should do only unimanual or only bimanual. During surgery, you may have to change strategies, and from unimanual to bimanual, or whatever is comfortable and whatever is safe for the patient that you need to do. So Sangeet's technique is also very good, but I just have one small criticism for that, is that like Gagan also mentioned, that often there is a dense adhesions around the disc and a little bit outside the disc, maybe not exactly at the disc, but in your video also you saw that there were some adhesions right next to the disc. Now the technique that you are doing is pulling it from the disc. I personally believe that now at this stage of your experience, you know how much to pull and up to what extent to pull and where to leave it, okay? But there are novice people and young people, they really do not know when to leave the traction. And if a new person is doing and a junior person is doing, I am sure they will end up with peripapillary breaks. Because in my own experience, when I was younger, when I was doing this center to periphery dissection, I myself have created breaks like that. So that is one thing I would like to maybe caution the young people. What is your take on that?
Yeah, first of all, I'm not demonizing bimanual surgery. I myself do it very frequently, right? Though my way of doing it is totally different, but I do it very frequently, bimanual. Yeah, you are right in many cases, like where we have very tight adhesions near the disc, or in which there is very thin retina, and sometimes the disc is not visible. It's so dense membranes are there. You have to start from the periphery and do a bimanual dissection. In those cases, I generally prefer to do a bimanual dissection. And when I do a bimanual dissection, I generally make cut from the periphery and make all around. I prefer to go 360 degree as you showed, and then start dissection. For the unimanual thing, how much to pull for beginners, I would advise is like if you feel that you can pull, just try once and just leave it. As soon as the membrane separates from the disc, just leave it, right? And if you're not able to do it for the first time or the second time, just leave it, do the other way, right? In the beginning, I will just advise this. But most of the time, as I said, it is not difficult. It doesn't bleed, it doesn't cause tears. And the dissection in almost 90% of cases becomes very, very easy.
So actually, coming to even cases like these, I would never attempt what you do, and rather the case that you also showed, I would never been able to attempt what you did. So I think that's really, really brave of what you do. I just wanted to know one thing, that if you have a bleed, so my biggest fear is, okay, you lift it up, fine, you probably, in the beginning, okay, you might not get into the right plane or you don't lift it completely. But, and if you end up with a large bleed, so, one of the problems that in diabetic surgery is that one is that you increase the bottle height to stop the bleed. Sometimes the bleed doesn't stop. So these problems do happen. But then how do you clear that bleed? Because you have the membrane still there, and you have the bleed also over there. So then that is basically making like a multi-layer vitroschisis now, because you have a layer of membrane, then you have a layer of bleed, and then you don't know where the retina is. So then how do you go and clear that bleed from there? In case
sometimes you do encounter, even if you're doing the other way around, you can have these kind of bleeds like over the retina, and becomes very messy over there. But what I advise is, as soon as you lift the membrane, and if you see that the disc starts bleeding, or even if a small ooze starts happening, just increase the bottle height, stop there. Stop for 3 minutes, right? And it will stop there only. It won't increase much. And definitely, if those kind of bleedings happen, every surgery becomes a mess.
Sangeet, what setting do you use? Because I think we are always worried that in detached thin retina, we are scared of using the cutter because of breaks, but you showed so beautifully that you are using only the cutter. So what are your settings and system which you are using?
I generally use the 10,000 cut rate.
Okay.
And 650 vacuum. I just control with the foot.
With the foot switch, okay. And you go in the shave mode for in constellation.
No, I use the core mode only.
So
even if my shave mode is there, I just decrease the vacuum, but a little bit, and the core, the cut rate remains the same.
But that's full control, because if we are trying to give a message to beginners, we'll tell them put the suction very low, because by mistake also, if it goes up and you have detached retina, you can get a break. And second thing,
see, one thing is, like, if you keep your suction low, now you won't be able to perform this type of dissection.
okay.
If you keep your suction high, the membranes itself, they will start coming into your cutter. And if they are not coming, it means that there is a second membrane below it.
Then you have to go
and then you have to explore with your forceps and see whether there is some membrane around that particular epicenter or not. And then you can just peel it off.
No, but even in cases like the combined detachment that you showed, so you go with the same settings? Because we usually have that feel that
same
kind
settings, same settings.
settings.
See, if you keep it low, it won't be successful. Then you'll have
Nowadays
problems.
with this MIBS, the retina remains stable. It does not jump so much. But it is very important that how the port is directed. So port should be definitely directed away from the retina. And then you can use those, what are those techniques described where you keep the cutter, fold back technique and all those, so that the membrane gets cut and the retina is spared. And also now there is a gap between the port and the cutter tip, and it is also a bevel tip, so it can go easily in between the retina and the membrane. So some amount of retinal safety is there, unlike the 20 gauge cutter, which were so difficult.
I had one more video, but because of the time I could not show it. In that video we had discussed all these things.
Dr. Sangeet, Dr. Gagan, great surgeries first. I am a lot of believer in what Dr. Sangeet does. I would have mostly tackled disc very often than not, and I generally start from disc. Few tips which I said, as Dr. Dhanashri was saying, if my fellow is doing, I don't let them touch the disc. The step of pulling the disc, I'll come, lift it up and give it to them. Because when they're more tentative on the disc and they just try to tease on the disc, they tend to cause more bleeds, and those bleeds happening within the interfaces. I'm sure most of us who start off with disc, we have one firm grasp at the disc, just lift it and leave it. And we are able to assess that plane has come off, the hyaloid just comes off, and then you can shift to your cutter. And secondly, if it starts to bleed, don't do anything. Just a masterly inactivity for a couple of minutes just stops the bleed. Very rarely have I encountered a situation where I have actually been in that big a mess with the disc. I will not touch a disc which is looking visibly vascular. Like this particular disc does not look that vascular. I would have probably started off at the disc. If it's looking too vascular, then one can avoid touching.
One more thing I would like to say, when I started doing this technique, we were using 20 gauge systems at that time, right? And at that time, what I used to do initially was make a small hole just near the disc to access the disc properly, to hold the membranes properly. And I had at that time designed a forceps which was just like your vertical scissors. It was not a scissor but a forceps. So just go in, hold it from there and just pull it off a little bit and it would come off. So now because of the smaller gauge, I'm not using that particular instrument, but it can also be.
Another thing, intraoperative OCT again helps here. On intraoperative OCT, one can actually find the plane where the hyaloid is already slightly lifted off the disc, and you go in that region and just pull it off, it comes off easier just to act.
Right. Thank you. Thank you, sir. Thank you, everybody. For the next talk, then I would like to invite Dr. Dhanashree Ratra. I think after discussing the two ways of dissection, I think the next thing would be the tackling the very morbid combined retinal detachments. I think ma'am is a senior faculty at and teachers of teachers from Shankar Netralaya, and I think it would be extremely nice to listen to what she has to say. Thank you.
Thank you very much, Gagan, for the kind invitation and also for this kind introduction. So I'll be talking to you about tackling combined retinal detachment, and after all these excellent surgeries that you have seen, I think there's very little remaining, but let me cover whatever is there. So the combined retinal detachment by far I think is the most challenging case that a VR surgeon will encounter in his lifetime. So the complexity of the surgery is increased by several folds. That is because this retina is very thin. Retina is very thin, mobile and ischemic, and there is no counter traction for your membrane peeling. So whether you are doing unimanual or bimanual, so the counter traction is not there. So since the retina is also very mobile, and the moment you try to peel the membrane, the retina also gets lifted. So you can see how difficult it is here for me to peel this small fragment of this membrane because the retina is so mobile. Also, the identification and the separation of the posterior hyaloid might be very difficult. Often you will see that the retina is so thin and the membrane is so thick, so it's like totally opposite. And it's also very fragile, and the moment you touch the retina, it gets has a iatrogenic break. So it's very important to have a very proper preoperative assessment and planning for the surgery. Make sure that you have the required instruments ready, or use the best quality instruments which are working properly, which are probably new, and also you have a good visualization system, because all this matters a lot. Otherwise it becomes very frustrating to work with instruments which are not working, or if the visualization is not good, that adds to your complexity. So make sure everything is in proper order. Preoperative anti-VEGF, I will not go into the details, but definitely it has a role to play, because especially in situations such as this where the extensive membranes, anti-VEGF works like a wonder. The only caution is that already the retina is detached, and hence there is a higher chance of contraction occurring, and further retinal detachment can get worsened. So here the caution is that you operate earlier. After injecting anti-VEGF, don't wait for too long. Maybe within 2 to 3 days you should operate on such eyes. This is an eye you can see where I think anti-VEGF has been given, and it is a large membrane at the disc. So this the first initial step is of course to do the truncation of the vitreous and remove the peripheral vitreous. And here I am using the scissors. So I actually like scissors for dissection. The advantage is that the scissors have a precise cutting, and the bleeding is less as compared to the cutter. But of course even the cutter is also good. So if you whichever is comfortable and whichever you feel happy with, you can use. So after you go into the correct plane of dissection, that is under the second membrane, then you can fold back the membrane and cut these adhesions, the nails which are there. So this I am doing unimanual, but you can also have a bimanual approach in this. So if you are in the correct plane of dissection, then the dissection is easy, and then even if it is unimanual, you can still do the dissection well. So you can see here the retina is not that much disturbed, and it is easy to do the dissection. So maybe we'll go to the next case. So this is a bimanual surgery. So especially in combined retinal detachment, I think bimanual would be better, because with bimanual surgery you have more control over the membrane, and also the retina is not disturbed much, and you can actually cut these nails quite easily without the retina getting pulled too much. So I think for combined retinal detachment you should plan for a bimanual dissection. So here there is a large membrane which is getting cut. So I definitely use this bimanual technique, and sometimes you can even if this is a very large membrane, here we are using only one chandelier, but sometimes you can use two chandeliers also to illuminate the entire retina well and do the bimanual. Sorry. So this is another situation where this is a combined retinal detachment. Here actually the whole retina, it's like a closed funnel at the disc. So the Sangeet's technique might not work here because the retina is also like inside. It's like one bunch which has gone inside the disc. So here the advantage is that you should do from center to periphery dissection, especially in combined retinal detachment. That works because after you have removed this vitrectomy, I have another video actually which shows you the combined retinal, the center to periphery dissection. So here maybe I'll just fast forward this. So you remove this, remove the peripheral vitreous, and then I have switched to bimanual technique here. So you can see this is the stalk which was there inside, and there was another membrane which you see inferiorly. Even this membrane was also actually inside the retina, like one bunch it had gone inside. So it becomes a little bit difficult, and you can see the pre-existing breaks are there here. So it becomes a little bit difficult. It is also important that you don't enlarge the pre-existing breaks, because the breaks get enlarged in the beginning of the surgery itself. Then the surgery becomes that much more difficult because the retina becomes mobile. So also do not remove this SRF prematurely, because this SRF which is there is actually thick and viscous, and it's actually giving support to your retina and does not allow the retina to get lifted when you are doing the dissection. But if you remove the SRF, if you drain the SRF prematurely, then the retina becomes even more mobile, because the fluid, the infusion fluid which seeps inside makes the retina more mobile, and then that creates more difficulty in your surgery. So this is the end of this thing, and this retina, you can either put gas or oil, but more often than not we are putting oil because of the multiple breaks and large amount of TRD or CRD which is there. Sorry. So this is another situation where there is a membrane and the hyaloid face which is plastered to the retina. So in this situation, I also start from center to periphery, but instead of pulling the membrane, I use either MVR blade to create a nick in the membrane, and then you can use the scissors to create the plane there. And then afterwards you can either do unimanual or bimanual, but this vitreous which is adherent to the retina all around needs to be removed. So I guess each technique has its advantage and disadvantage. So whatever you think is good for you, you can do. So center to periphery can work quite well for combined retinal detachment. So this is the cutter which I am using for combined retinal detachment. I generally use a 23 gauge system. Sangeet has shown with 27 gauge system. So you can see even with a combined retinal detachment, the retina is quite stable and it does not jump as much as you would expect it to be. However, you still have to be very cautious because the retina is thin, mobile, and you can end up with multiple iatrogenic breaks. So you need to be very, very cautious. Most important is that you have to dissect the entire fibrovascular proliferation from the membranes, from the breaks. And if you have created iatrogenic breaks, then it is more important to clear all the breaks of the fibrovascular membrane, because any residual fibrovascular membrane is going to contract and will lead to recurrence. Role of scleral buckle, there is actually not much role because most of the breaks are actually posterior and you cannot buckle them. And it also will increase your surgical time and higher chances of corneal edema. There is also a higher risk of anterior segment ischemia because it's already in a combined retinal detachment is already in a very global ischemic state, so you have to take into account that. However, if there are any peripheral breaks or there are breaks where you have not been able to remove the vitreous or the fibrovascular proliferation, and if they can be buckled, then maybe you can try and buckle these situations in this situation just to prevent any recurrence. But I have almost never done any buckle in a combined retinal detachment. But just for the sake of discussion and for completion of this, I have added this point here. So to conclude, that diabetic combined retinal detachment remains the most challenging surgery that a VR surgeon will encounter. Retina is very thin, ischemic and fragile, and the risk of iatrogenic breaks are very high. Combination of techniques and combination of instruments such as multifunction instruments also can be used. Removal of the fibrovascular tissue from near the breaks is very important. And despite good anatomical results, sometimes the visual outcomes are quite poor. So you need to counsel the patient accordingly. Thank you very much.
Thank you, ma'am, for this.
Cataract is not much. You are still able to visualize the retina. You think you will be able to do the surgery. Then in these situations, I do not do a combined surgery. I mean, I do not do a phaco because a combined surgery always creates more inflammation and higher chances of all problems. Like I said, even NVG and all can develop. So in this situation, I first do the retina surgery, settle the retina, and at the time of the silicone oil removal, then I'll plan for the phacoemulsification. But if the posterior disease is less, that means the fibrovascular proliferation is small, the amount of RD is small, then I do a combined surgery.
So for combined retinal detachment, one thing Dr. Dhanashree has highlighted is to remove the membranes to the maximum. If there is a break, you can't leave the membranes. In normal TRDs, you may still leave some areas of traction on the nasal side, which is not affecting the macula, but for combined, it is not. You have to remove all the traction which is there. Second is like in combined retinal detachments, as she mentioned, the subretinal fluid is very thick. And so you do a fluid-fluid exchange before you start attempting the fluid-air exchange to completely flatten the retina. I think this is another point I'd like to make.
And anybody using scleral buckles actually, or a belt buckle for that matter, just to support it?
No, I
No,
know. Because initially I used to do when I just completed my fellowship, because of fear of all these redetachments, but I realized that the chances of anterior segment ischemia, they increase very, very high. They become very, very high, and patient will come to you with recurrent vitreous cavity hemorrhages or neovascular glaucoma.
So secondly, the choice of tamponade, I think usually what we follow is that if we have a combined detachment, though we are also shifting from that, but if you have a combined detachment, especially chronic TRDs and with a combined detachment, or a chronic TRD converting into a combined detachment, so oil usually was the earlier school of thought. But then as of now, I think what I hear and what I also see is that oil per se action on the disc is way catastrophic than probably using gas. So what's your take on that? I think.
So for superior brakes or peripheral brakes, gas is quite okay. You can put gas. But sometimes if you have multiple brakes or if you have inferior brakes, then I don't think the gas will be that good. So oil would be a better choice. Yeah.
So for me, if I'm able to settle the retina and laser the brakes, I will prefer to do gas only. And I've removed all traction. That is the minimum thing. You have removed all the traction. I'm able to settle the retina, laser the brakes, I'll just do gas. If there are large breaks like other indications of oil, I'll definitely go with oil at that time. Just remember one thing is like if you have an open break, there is fluid still between the retina, still under the retina. Then you can't leave it with gas only because this fluid takes sometimes like months together to go. And once the gas has gone and you are still have an open break, it is again a disaster. You are going to land up in a recurrent retinal detachment condition.
And also, not for a combined detachment, but sometimes you have these very high TRDs, and if you're able to kind of manage the membrane, and you're very sure that you've not caused any iatrogenic break and there is no break. So what is your, your threshold of using a tamponade, even if you're a little scared of something, or you're able to leave a very high TRD and let it settle on its own? So what's the take on that?
So if just there is a TRD and there is no iatrogenic break, if you are sure there is no iatrogenic break at all, then actually I don't do any tamponade. Sometimes I may leave air, that is for hemostasis, but I don't do any iatrogenic retinotomy to drain the fluid. I just leave that TRD as such because I believe that it is better not to create an unnecessary break. And over that period, over the time, the retina will settle. It may take long time. Sometimes if there is a very chronic detachment, then it may take some time. But I still feel that it is better to leave it that way rather than to create a retinotomy and then give a tamponade.
So I generally, in these kind of situations where there's a high TRD and there's no break, what I generally do is, although it's a controversial thing, I generally put SF6 in those lesions and ask the patient to lie prone. What happens is that mechanical displacement of the fluid goes to the sides, your retina gets settled quickly. as we do in the submacular hemorrhage cases.
But you don't do any retinotomy?
No retinopathy.
Just a tamponade.
Yes.
That I also do, but I give only air.
Yeah, that's
Yeah.
true. That's
Yeah,
clear
that is
also.
that is what my question actually was, because I used to do that, and then there was one case which we had done a few days back, and with a very bad outcome, and the other I done elsewhere, and we left a very high TRD, and I was for 3 weeks I was just going on thinking whether this is really going to settle, and
It
in
takes
3
months
weeks
together.
it really settled very well.
Yeah.
So I think that is one thing, that if you don't have a nitrogenic break, maybe leaving a high TRD with some fluid is not something to be scared of. Uh, so that was that. So any additions from Dr. Ritesh and Dr. Darius?
I want to ask, I think already Dr. Sangeet has partly answered the question, but what is the endpoint of your route? Like I agree in CRD you have to remove all membrane, but for other cases where you have proliferation and membrane, do you leave the nasal areas or you go after every shred of membrane? What is your endpoint of your vitrectomy?
Yeah, I try to remove everything, but sometimes if it is in the cost of causing breaks and putting in oil, then I'll definitely leave it.
See, you can leave islands of tissue which are like very adherent, which you are not able to remove. You can leave some few islands, that does not matter. But you should not have any tissue which is bridging 2 points. Any tissue bridging across 2 points will contract. So even if you have left a very large island which is across 2 points or across superior inferior or across right left, that will contract. So that you should not leave. And any peripheral sometimes you can leave the peripheral vitreous skirt. It might not be very easy to remove. But again, if the peripheral vitreous skirt has a band of vitreous which is coming posteriorly, that is again going to contract. So don't leave any connection between anterior and posterior. You should cut off any connection. So fibrovascular polyps also, you cut off the connection anteriorly. You may leave posteriorly some amount of tissue if it is not possible to remove. But if there is an hydrogenic break, then you have to remove it. If it is not possible to remove, then you can just do a retinotomy and cut off that entire tissue.
Thank you. Thank you, everybody. So now coming to the last talk, I think I was attending a leadership program a few days back, and in that they used to say that there is always this person who clears up all the mess at the end of every party. So I think inviting Dr. Ritesh to finally clear up all the messes that we have created since morning. So Dr. Ritesh is a senior faculty at LV Prasad Eye Institute and carries a lot of big name papers and fame along with him, and it'll be lovely to help us sort out the messes that we create.
Thank you, Gagan, for those kind words, and very good morning to all of you. Whatever my previous speakers, seniors have been talking about, in this particular set, I'll show what all can be done to make things messy. And so as we were talking about, first create a bit of mess. Okay, so as we were talking about diabetic vitrectomy, the horizons have expanded a lot, and we go ahead with surgery in quite a few percentage of cases, but complications are a part of diabetic vitrectomy, especially there is a significant learning curve involved, and 5% of patients, what has literature been saying, will ultimately develop some form of complication that may require surgical interventions. Initial in your practice, these complication rates are high. Slowly, as you go more and more diabetic, comes down. So I would broadly classify complications of diabetic vitrectomy as intraoperative and postoperative. Some of them are quite easily manageable, don't cause much of an issue, such as corneal edema. This happens directly because of longer duration of surgery, frequent IOP fluctuation. If you keep doing during the surgery, you keep going bottle height up, down, those will cause corneal edema to come, and you can debride the epithelium. I'm little wary of doing it. I want my surgeries to happen much faster. Why am I scared of it? Because in diabetics, if the anterior segment perfusions are not great, you may risk persistent epithelial defects also. You develop fold in Descemet's membranes. If you have a pseudophakic eye, you can inject viscoelastic, tighten the anterior chamber. You can take away of those folds. A lot of people, if you develop a lot of stromal edema, they used sterile glycerine also dipped in kind of sponge and put it on the cornea to reduce the swelling of the cornea. You can have lens opacities. You may touch the lens during surgery, especially when you're trying to indent and do bimanual dissections. A prolonged surgery will also cause cataractous changes. Serum glucose fluctuations can also increase the chances of cataractogenesis. As far as possible, we try and finish the surgery if the touch is not too big, and then tackle it at a second stage. But if it is too big, sometimes it has happened that I've shifted to a cataract, completed the cataract, put in an IOL, and then gone ahead. So those things happen quite often in any vitrectomy, more so often in diabetics, it does happen. The important intraoperative complications we tackle often is intraoperative hemorrhages. There are roles of preventing this. We use pre-op anti-VEGF. It kind of dries up the membranes. I generally prefer giving 48 to 72 hours before the surgery and then take up the patient for surgery. One dictum which I give my counselors and my team is, do not give the anti-VEGF till the surgery date is fixed, fitness is done. Because if you give anti-VEGF and then you don't operate, the crunch is really bad sometimes, difficult to manage. Our wide-angle viewing systems have made life easier in these cases. How do we control it on table is through controlled infusion. We have the VGFI from the Constellation, which is vented gas fluid infusion, which raises the bottle pressure. Manually, you can raise the bottle height. Diathermy, the stumps, the bleeders, identifying, and bimanually, Dr. Gagan had shown very nicely how you can identify those bleeders and take care of it. But the most important thing for hemorrhage is finding the right plane. If all the previous speakers have talked about find that vitreochoices right plane. If you are in the right plane, as you can see in this video on the left, the toughest Lucas membrane can go off quite smoothly without having caused much of a problem. As long as you are in the right plane, you are able to dissect, separate that very nicely, and you leave behind a clean retina. Look at what happens on the right when you don't find a right plane. This manipulating with a manipulator, and then suddenly you're not in the right plane, the bleed starts to happen. You are thinking, no, it's a small bleed, let me keep continuing the dissection. You don't realize when you're doing your vitrectomy, you're continuing with your cutter, you're not maintaining that pressure. And then the bleed starts to increase, more profuse, and in no time you'll have a large area full of blood and your view starts to get compromised. And that's what happens. And then the first mistake when everybody does here is, as soon as this happens, they take their instruments out. Now, the moment you come out here with your instruments, you have again caused a hypotony, the whole blood gets spread out. So you have to ensure that you don't leave your tight chamber there. You don't want to land up with a situation like that. How do we manage it is again through raising bottle height, identifying it bimanually, and cauterizing each of those bleeders which is causing it, separate the membrane which is pulling on the vessel, and you will be able to tackle it. Something which we are doing now, we are a group of glue users. So we have this glue study, which the results will be coming out soon, showing one of the cases from there. So this is a case wherein this is typically we are doing it for disc bleeders which do not get controlled. So this case of diabetic, we have removed the membranes, there's a disc, prolif, came out easily, and then we realized then there is a bleeder happening from the disc. Bottle height was raised, you try and press on the disc with your blunt cutter, but it kept on oozing and oozing again. Tried multiple, did fluid exchange, again it is filling up. So such eyes, if I leave it on gas, by tomorrow I may have a dispersed heme. So herein we have started what we are doing is using fibrin glue, a drop of thick followed by a drop of thin glue you put on the disc. Initially glue was actually designed for CNS surgery wherein you were using this as a coagulating agent. So you just leave a drop of it, a coagulum forms on the disc, collect it over the disc and just leave it there. You complete your surgery, laser. This case was left on air. I'll show you the day 1 post-op. That's the glue coagulum on the disc, and that's day 7, the glue is absorbed. And you are able to avoid that messy first day, no view kind of a fundus. So there's another technique which you can try doing if your maneuvers of controlling disc bleeds are not working. I'll finish a post-operative complication here itself, which is linked to the intraoperative complication of bleed, which is post-operative vitreous cavity hemorrhage. Now, their rate is about 75% can have some amount of vitreous hemorrhage post-vitrectomy in PDR. Most of them, it resolves within 2 weeks in vitrectomized eye. They can be classified as early and late. Early, which happens within the first 4 weeks of surgery. late, which happen after 4 weeks of surgery. And most of the causes of early post-operative vitreous cavity hemorrhage are some amount of residual clots that you have left in the peripheral vitreous, any iatrogenic injury which you fail to identify, or a bleeder which you fail to identify on table. You have left an incompletely removed fibrovascular tissue which is still pulling onto the membrane, or rebleeding from a blood vessel breakdown secondary to the damage during the dissection of these membranes. Late POVH happen because of an ingrowth which most often happens at the sclerotomy sites. How do we manage? Early, as I said, first we give it a time to kind of resolve on its own, 2 weeks of a period of time. Subsequently, if it doesn't happen, how do we prevent it? I'm talking about first, I'll talk about that. So a complete removal is necessary. You do a good laser. At the end of your surgery, before you close the eye, you lower the IOP. I generally take it down to 10, not under air, it's under fluid, take it down to 10, look for any bleeders, identify those, cauterize those. Then I do my fluid air exchange. And I don't close on a hypotony in a diabetic. If I have a slightest of a doubt, I'll put a suture. I don't mind doing that, but I'll not close the diabetic eye on a hypotony. That causes much higher incidence of post-operative vitreous cavity hemorrhages. As I said, anti-VEGF is something which really helps in reducing the risk, and the RCTs, which was a meta-analysis which was done, patients in which anti-VEGF pre-treatment was given, there is much less chances of post-operative VHS. Management, 2 weeks, don't do anything. If it doesn't resolve, you can go ahead with vitreous lavage. Vitreous lavage is basically allow the blood to wash off, go inside, identify your bleeders, try and see if there is any anterior laser missing. You can go that, indent well, clear your peripheral vitreous cut if some blood is left there. Intravitreal bevacizumab study has been done in post-operative also to take care of this post-operative vitreous cavity hemorrhage. That's a video showing a lavage. So that's just fluid coming in and the cutter aspirating. Eventually you reach that big clot which is sitting on the retina. You go and aspirate that, and your view improves, and then you go in and see which areas your laser is missing, and then you can add more lasers. So do a fluid air exchange, clear off all the blood which is sitting on the retina, and then complete your laser. Coming to late post-operative vitreous cavity hemorrhage, herein identifying the cause is very important. It's very important to do a good UBM of the sclerotomy site. You will be able to pick up these fibrovascular ingrowths into the sclerotomy site. Then you can go and target them. Generally, if I have late vitreous cavity hemorrhages, or even now recurrent vitreous lavages, if I need to do, I add anterior cryo to make sure that the anterior retina is well treated, especially around the sclerotomy sites. Switching back again to an intraoperative complication, which is an intraoperative break. No one wants it, but still we get it sometimes when you're operating. And it has been shown that intraoperative tears can happen in about, the study which was done this way back in 1983, the incidence were pretty high, and very often these tears are closer to, in the anterior tears are more closer to the sclerotomy site, while posterior tears are more closer to around the arcade area. That's what the study said. The incidence have come down with improved instrumentation, but still pretty good. What 10% of cases can have these one or more tears. Posterior retinal break usually caused by traction as you're dissecting this fibrovascular proliferation. And I'll show you this video, which not a great one to see, but big learning about what we were talking about, how to keep the mouth of the cutter away from. So this is a diabetic vitrectomy being done, and there was this patient had a macular hole with some amount of traction around it. So that's the hole. And as this cutter is, where membrane is being trimmed, you see how the hole has got enlarged. There's just a moment wherein the hole suddenly became double because the mouth of the cutter was not pointing in the right direction. Then as you're doing this bimanual dissection, instead of doing a blunt dissection, you use your cutter. If your plane is not right, you start using your cutter. You will see as soon as you remove the membrane, there's another hole sitting underneath it. See there. So You have to be careful how your direction of your cutter is. Use these cutters. Now we have 25, 27 gauge cutters. Use them as a good blunt dissecting instrument. They have these beveled edges. You don't need to be on a cut or an aspiration mode so quickly. Create your plane nicely, and then you can start segmenting these membranes. Going forward, the break happens. The incidence of post-operative complication of retinal detachment post-diabetic vitrectomy also comes in. The incidence is much higher. It's reported about 5% of cases, and it happens more with prolonged surgical durations, more number of intraoperative breaks. Complex detachment which require bimanual surgery, the incidence of post-operative retinal detachment is also high. One such horrific case that we had to deal with, it's a recurrent detachment post, it's not playing, sorry. Unfortunately, it is not playing. Can I just, we have time to just pause and see? Yeah. आया नहीं इसका, प्ले नहीं हो रहा वीडियो. Yeah.
So about the disc bleed, I think that is one of the most dreaded complications. So you try whatever, like you increase your bottle height, you stop for some time, still the bleed does not stop. Ritesh has also shown he has used glue over the optic disc, or some people use triamcinolone over the optic disc. What you can do is you can raise your bottle height more than the diastolic pressure at that time if the bleed is not stopping. The bleed will then stop. Just wait for some time, and then you keep lowering it by 5 millimeters of mercury every time, and you'll see most of the times then you can get a control over the bleed. If the bleed still does not stop, it's always better to close the case and take the case 1 to 2 weeks later, rather than going ahead with the case at that time.
Yeah.
I don't know. I've never.
I don't think so, but with the membrane, I think it will be an excessive crunch. I think one important thing is that if you have a bleed, I think it's best to just keep clearing it, because the blood sticks more adherent to the retina than anything else.
If you keep on clearing it, it will keep on bleeding.
No, what I mean to say is that don't let a very big mount form and then you kind of tackle it type.
Two more things which I do is, if I have cleared my posterior pole significantly, putting a small bubble of PFCL there, if the rebleed happens, it goes over it. Removing it later becomes a little easy. Number two, a mistake which I felt I used to make a lot often is I used to continue doing vitrectomy and leave tackling bleed for later.
Yeah,
But I don't prefer doing it now. As soon as the bleed starts, if there are dithermizable points, I'll start dithermizing them then and there, the stumps. I don't wait that a clot, I'll do it later. I'll multiple times go in and out with my dithermy, but I don't let those clots happen or bigger bleeds to happen. The video is here, so I'll just show the video. So this is a case of recurrent detachment with PVR post-diabetic vitrectomy. There was inferior PVR, inferior membranes. Yeah, so we stained it with brilliant blue, got to the plane wherein used the brilliant blue to help me identify this membrane, and then you start peeling it from the center to the periphery, and there are large breaks which have happened. They're almost like, as you're doing it, the breaks tend to enlarge, but herein I was more concerned about getting this each and every tissue now out, because it's something important for us. I was okay to have a little larger peripheral retinotomy, almost like a retinectomy there. I relaxed that area, did a retinectomy localized, and kind of made it much larger single break. As Dr. Dhanashri was talking, your membranes are pretty bigger ones, you can do that, and then you end up putting oil, and the patient touchwood did well. So it was inferior, it was away, so I was able to tackle it nicely. So thank you.
Thank you.
Any role of interface vitrectomy, Dr. Sangeet? Do you ever switch to air if you have a lot of bleeds intraoperatively?
Yeah, if your blood disperses in the vitreous cavity and keep on bleeding, what I generally do is I switch the patient to air, and you see the view becomes better when you switch off onto the air. And you limit the blood to one place, stop it there, and then you can evacuate. Yes, yes. Yeah. Two things.
Yeah, please.
Once we do a diabetic vitrectomy and if we inject oil, and the patient looks fine on the table, but next day if you encounter blood, subretinal, sub-oil blood, what should be the next, whether you should go again immediately or you should wait, or?
A difficult, tough one. So it's a complication which we don't like to see. So initially I will not be, if amount of blood is not too much, I would ask for a positioning, strict prone positioning. Try and see if that blood over the next 1 week moves away from the center. If it is away from the macula and the patient is okay with it, I will wait on and I'll probably tackle it later with oil removal. If it starts to organize on the macula, then I would go in probably for an early evacuation, say within 2 weeks, 2 weeks around, I'll go for it.
There was 1 case, I waited for 1 month. I thought blood is getting clear. But after 1 month, the posterior pole looked very bad.
Yeah,
All
so
fractioned and...
So 2 weeks is generally, before it starts to become yellow, I'll go in, and if it doesn't move away from the fovea, you can make out. So as you're following up this patient, you can see the quantum of the blood is coming down, or is it displacing inferiorly. So I'll be very happy if I see this position and see a streak hyphema coming in. I know the blood is getting pushed more anteriorly. I'll be happier that way. But if not, 2 weeks I'll go in and...
Yeah, but I think very large, thick bleeds, I think you will know that this is not going to go.
Yeah.
So in those, I think it's best to kind of go in within 2
Yeah.
weeks.
2 weeks is also done so that at least the bleeders who have caused this bleed are in the meantime shrunk and coagulated. So that when you go in again, you don't encounter the same. You can.
You can. You can do it.
That was the same thing I was going to ask. Is that subsilicon, these blood clots, what to do? So recently I've started, if your retina is attached, one thing is there. If your retina is detached, don't do that. If your retina is attached, now what if you can wait for 2 weeks, that is fine. And still that large clots are visible because they form very tough membranes which are very difficult to remove later on. So now I've started using TPA before going in again. I just inject TPA 2 to 3 hours before the surgery. It becomes lysed and it's easy to remove at that time. But if your retina is detached, just vary off that the open breaks, the blood which is lysed will go subretinal, and that will cause problems during the surgery. Yeah, same, the intravitreal dose.
Give it a try. I've not done it.
Yeah,
give,
that's
give
a
it
nice
a try.
take home.
Recently only I started doing it.
Give it a try.
Right. So I think with that we come to the conclusion of the session. I think we need to go for the next session. I would like to please call everybody for a group photograph, please. I think the audience can also join.